shoes are from.
Thanks. You're good to go.
All right. Well, welcome. It's good to be here. So today we're talking about diabetes and your feet. And I thought I'd start out with a little bit about me, who I am, and why I'm talking to you about this. And so first of all, my name is Emily Opp, and I am a podiatrist and lower extremity wound specialist here at Summit. We're a new service here at Summit, and excited to be here. We've only been here for a couple months, but there's usually no shortage of patients, even at the moment. So people with feet, right? We see a lot of those, and diabetes is one of the main things that can be problematic, and one of my main things that I see on a regular basis. So today we'll just talk a little bit about diabetes and how it affects our feet. So why are we talking about feet, first of all? Well, in terms of diabetes, it affects your entire body. As we know, there's different parts that are more affected than others, and feet are one of the main things that we see can be affected. So other kind of major spots would be things like your heart, your cardiovascular system, your kidneys, your eyes. There's all sorts of things diabetes affects, but your feet is a huge part of that. When we're talking about feet, diabetic foot problems are mostly preventable. We can keep the feet healthy if we keep our bodies healthy and the diabetes itself under control, and we'll talk about that a little bit more. And early care, if you do have foot problems, can end up saving your feet and truthfully possibly save your life. So we'll talk a little bit more here about all those different things that happen with our feet. In terms of the diabetic foot, what qualifies as a diabetic foot? I like to say that someone with diabetes with at least one foot qualifies as a diabetic foot. In terms of a true diagnosis, we usually will say that someone who has been diagnosed with diabetes who also has at least one of these problems. So nerve disease, known as peripheral neuropathy, bad circulation, like peripheral arterial disease, Charcot foot, which is its own kind of rare complication from diabetes that creates joint damage, someone with diabetes with a foot infection, an ulcer, gangrene, amputation. Any of those would be reasons to consider this foot as a high-risk diabetic foot. Some common diabetic foot problems that people have are things like dry, cracked skin, calluses, ingrown toenails or thick toenails, foot ulcers, or open sores that don't heal, infections, changes in your toes or foot shape, and destructive joints, which again is that Charcot foot. So symptoms to look out for here: tingling, numbness, pain, cramps in your legs. Those all signal to me that there could be something like neuropathy happening or that nerve damage. Again, ingrown toenails, redness, swelling, changes in temperature. And we'll talk a little bit more here about all of these things in detail. So these are the common things that we see with anyone who has diabetes and why this matters. So about 25% of people with diabetes will end up getting a foot ulcer. Most amputations with people who have lower extremity amputations, toe amputations, that type of thing, start because of an ulcer. And most ulcers are going to start with a callus, a blister, possibly a puncture wound. And foot infections themselves can then lead to things like hospitalization, surgery, amputation, and death. So this is a big problem. 25% of people is not that small of an amount. Here are some really staggering and sobering statistics, and that goes back to this 25%, 1 in 4 will develop a foot ulcer. Once you have a foot ulcer, the amount it takes to heal that is usually ranging about 3 months to sometimes over a year. It is not a quick process. And then the recurrence of ulceration at 5 years, so say you had one 5 years down the line, we see 65% of people may have another one. So the recurrence rate is pretty high. It happens to people and then it happens again. Your diabetic lifetime risk of any lower extremity amputation is 1 in 5. That is not a small number. That is a lot of people with diabetes who end up getting some type of lower extremity amputation. And patients with a foot ulcer have a 5-year mortality rate of 50 to 70%. About 10% will die within the first year of their first diabetic foot ulcer diagnosis. When we look at what causes those, the leading cause of death for those people, it's usually cardiovascular disease and infection. So this is not a small problem. It is a huge problem. We actually see that this is higher than a lot of cancer rates, right? So why do these foot problems happen? Well, again, we go back to the fact that diabetes causes things like neuropathy and poor blood flow. So if you have neuropathy, you may not feel blisters, cuts, pressure from shoes, or calluses. If you have poor blood flow, your wounds are not going to heal very quickly and they're more likely to get infected. Diabetes affects all of the cells in our body, but one system specifically is our immune system. And if we have very uncontrolled diabetes, we don't have the ability to fight off infection. So infections then are often worse than they would be in someone without diabetes. And your foot anatomy itself predisposes people to complications. So we see that deformity creates pressure problems, and diabetes and neuropathy eventually can create deformity. So those are things like hammer toes, bunions, and flat feet, and high arches, and all get issues because of these pressure problems. And then with the foot, we've got 26 bones approximately in each foot, and there's not a lot of tissue between the ground and those bones. And if you have a wound under that area, you're at higher risk of then developing a bone infection because the bone is not that far from the tissue that's affected. So a little bit about diabetic neuropathy. So nerve damage here is usually caused by an excess amount of glucose and lipids in our body, and that's just the blood sugar and the fats and everything that we have going on with our damaged metabolism that happens in diabetes. The diabetic lifetime prevalence of getting neuropathy is about 50%. So about 50% of people with diabetes will end up getting neuropathy. And if you have neuropathy, you have a 7-fold risk of developing a foot ulcer. So again, it's a huge leading cause of why you might end up getting a foot ulcer. Diabetes neuropathy kind of affects a lot of different systems. So we see what's called a sensory neuropathy, where you're going to lose the ability to feel things like hot versus cold, anything that's a sensation. You start to lose motor neuropathy as well. So that's the nerves that affect the muscles. So if your muscles are not firing as accurately or strongly as they once did, you end up more likely to get things like hammer toes. You might end up walking on the front of your foot a little bit more than back on your heel. You end up getting some muscular weakness with that. And they also cause something called autonomic neuropathy, which essentially is the loss of our ability to produce things like sweat. So we see all of those different areas of neuropathy affecting diabetic foot. And so we end up getting tingly or numb feet, difficulty walking, trouble sleeping because of burning, tingling, increased falls, lack of sensation. You can't necessarily feel sharp versus dull, hot versus cold, pain versus pressure. You might have sensitivity to touch where you have burning, tingling, and very I call it hypersensitive. Light touch is uncomfortable, gives you the creepy crawlies up your neck because it's just not a comfortable sensation. You have shooting or burning pain, and then eventually you might end up with an ulcer that is present and you may not know it because you may not feel it. So all of those things are a serious problem with neuropathy. Now a little bit about the bad blood flow or the peripheral arterial disease. Peripheral arterial disease is caused by a lot of things, but diabetes is definitely one that can affect and cause this. So about 1 in 4 people with diabetes have poor circulation. Other significant risk factors for developing poor circulation can be things like smoking cigarettes or any type of tobacco use, having high cholesterol, and again, diabetes. So diabetes plus peripheral arterial disease, if you have both at the same time, have about a 4 times higher than national average amputation rate. Because again, blood flow is so important for healing. And if we don't have good blood flow, we don't heal as well. More likely to get infections, and then more likely to end up with amputations. Our signs and symptoms of peripheral arterial disease often are things like loss of leg hair. You may not have as much leg hair as you maybe once did, or maybe your toes don't have any hair on them and maybe they once did. Your foot itself might feel cold all the time. Your skin might be a little bit shiny or thin looking. Sometimes it's a reddish or purple color, and especially if you're getting any pain or cramps in your legs or your calf muscles when you're walking, and you have to stop and rest and recover from that for a couple minutes before you keep going. That's a good sign that you're running out of oxygen there, and your muscles are needing a little bit more oxygen, needing a little bit more blood flow. So that's one of the signs to look for there. back onto the little blurb I said earlier about a compromised immune system. Again, diabetes really affects all sorts of our systems, but when we look at uncontrolled blood sugar, it also inhibits that immune system response. And so you might end up being sicker than you look if you have an infection, and your infection can spread more rapidly. So I see a lot of times patients in the hospital who, they've got a diabetic foot ulcer, they have a huge abscess or something kind of brewing in that area. And if we look at their cells, we look at their labs, they don't look all that sick. Their lab counts are not showing us as sick as they actually are and as bad as that foot actually is. So sometimes your body is just not showing that same response to infection that someone who doesn't have diabetes might show. When we talk about blood sugar, and we're talking about chronically high blood sugar, it's one of the things that in and of itself, it is an independent risk factor for ulcers, infection, and amputation. So even if you don't have neuropathy, even if you don't have bad blood flow, but you just have a very uncontrolled blood sugar, you are more likely to have an ulcer, more likely to have an infection, and more likely to undergo amputation, as well as all of these things kind of lead to that mortality after that diabetic foot ulcer. So a healthy person who is not diagnosed with diabetes quite yet is falling under that 6.0 for their A1C, and then we have this pre-diabetic range usually is calculated to be around 6 to 6.5, and if you have diabetes, A1C over 6.5. That is a test, by the way. The A1C test is a test to show sort of an average of your blood sugars over the past 3 months. And so it's something that if you are diabetic, you're very familiar, hopefully, with getting one of these. But it gives us a good information of where you live in terms of where your blood sugar is at. And it's so important because blood sugar can damage your nerves, your blood vessels, your immune system, and your ability to repair and regenerate. When we look at some of the studies involved with A1C, we see that every 1% increase in the hemoglobin A1C is associated with about a 10 to 15% increased risk of developing a diabetic foot ulcer. So there's a higher risk of infection again and delayed healing with these higher levels of A1Cs. And really the threshold cutoff to kind of keep in mind is that any A1C over 8 has a significantly higher rate of ulcer recurrence, amputations, and complications with healing. So that's that number you really want to work on trying to make sure your blood sugars are well controlled so that you at least stay below that. And this is a true point for anyone with diabetes. If I see someone who needs surgery for some reason, say they have a bunion and they want to get their bunion repaired, and they're a diabetic and their A1C is over 8, I will not operate on them, and most people will not operate on them because your risk of infection starts to outweigh your potential to heal. So we just have to be really careful with those things. So the higher the A1C, the higher the risk. At something small that you think was maybe just a callus or maybe something little that wasn't a big deal can now become a limb-threatening one. So what does a foot ulcer look like? I think a lot of patients are not totally sure, what are we talking about when we're talking about an ulcer? We think of ulcers like stomach ulcers, and I don't know, they're hard to visualize, right? So what I would always encourage you is a sore on your foot that doesn't heal is probably an ulcer. It's one that is just not closing up. It seems like it's oozing. It's always a little red. Just hasn't gotten any better. That's most likely an ulcer. But really, truly, they are often under pressure points. So a true diabetic ulcer tends to be on the bottom of your foot, under your toes and heels. You can get ulcers in other places on your legs, venous ulcers and different types. But for diabetics, we tend to see more pressure-related problems. And sometimes they are on the top of your foot or on the side of your foot, but most of the time they're on the bottom where you're not looking at them and not seeing them. Any open area that you are like, hey, I don't know about this, it's worth probably coming in and talking to your doctor, because we want to make sure that you don't have an ulcer and that it's not just lurking around for months at a time going unnoticed. So how do ulcers develop? Well, like we just talked about, over time, they are developing a lot of times from pressure. So sometimes it's something, random. Someone steps on a nail and all of a sudden they have a wound on their foot and now they have an ulcer that they have to heal, or maybe they had a cut or something like that. But a lot of times it's from repetitive and excessive mechanical stress. So as that neuropathy happens, we end up getting more likely to get those hammer toes and sort of that curling up of the foot that we see. With that, your pressure is now different. So everybody has a nice fat pad that lives on the bottom of their foot. as that toe sort of starts to curl up, that fat pad shifts, and now your knuckle is kind of grinding into the ground. That knuckle pressure is going to sort of cause this cellular mechanical response that creates a callus in that area, and then the callus in and of itself can create problems. So I always kind of describe an ulcer as basically pinched skin between a bone and a callus, and that pinched skin starts to break down. So early signs of an ulcer are usually just bruising underneath the callus. And people are like, just my callus, got some kind of like purple or brown in it. And to me, that's always concerning. A callus that is colored with any type of bruising is always a concern. And then as that pressure persists in that area, that skin underneath that ulcer starts to die, that skin underneath that callus starts to die, and that's what creates this full thickness wound in that area. And eventually it can get deep, it can go all the way up to the bones, it can definitely progress rapidly. Here's your fair warning. I'm going to show you some real pictures of what an actual ulcer looks like, and we'll kind of walk our way through how an ulcer sort of starts. But if you don't want to see real pictures, this is your one. So in the top left corner here, we have someone getting what's called a monofilament exam. We'll talk about that more in a little bit. This is testing for nerves. That person has a normal foot. We see normal healthy skin, maybe some hammer toes where those toes curl up a little bit, but that looks totally normal. But because of those hammer toes, we now look at our middle picture. We see that those toes have started to curl up. And then here on the bottom, we start to see this callus formation that is happening because the toes are now creating a pressure problem, and that joint is grinding into the ground, and your body starts to create callus. Nothing on this slide is worrying to me besides the fact that we have some areas to watch for, right? So we're watching that callus. We would trim up that callus in clinic to make sure that there isn't any thick callus causing problems in the future. Maybe talk about different types of shoes or ways to offload pressure. But from this standpoint, nothing here is yet problematic. It's on its way to be problematic, though, if we don't address those things. And so here's our more problematic pictures. So on the left on this side, we have what's similar to a pre-ulcerative callus. This is where that callus starts to get some bruising. I had a hard time finding a good picture of this, and I should have just taken one probably, because I see this all the time, but a lot of times people don't take pictures of things that are pre. They take pictures of things that have happened. So the pre-ulceration is that hard one to visualize, where basically that callus starts to get bruising underneath it. Then as that skin continues to break down, we see this middle picture. Now, one of the things I see very often, very regularly, is that a callus someone will come into my clinic with a callus that is living on top of that ulcer that you see in the middle. So if someone says, I have a callus, but it's oozing and leaking, and I'm getting some weird drainage in my socks, and maybe there's a little opening to it. If I then take off the entire callus, what we see living underneath is this ulcer. So this ulcer is a full thickness ulcer. It goes all the way through your skin to the subcutaneous tissues, and we can see that in that picture. And then on the right here is an example of when that might start to get infected, what you might see. So if you don't see this happening on the bottom of your foot, what you might see instead is that your toes are starting to turn red. And that might be because there's a bad infection brewing. And from there, things can get much, much worse. I wanted to keep things a little bit, it's around dinner time. I don't know what people are doing. So I just wanted to make sure that we were able to stomach this. But things can definitely get much uglier, okay? So talking about infection, like those two toes that were turning red, some signs of infection that we don't want to miss are things like redness, warmth, swelling, drainage or bad smell, new pain or pressure, especially if you are numb at baseline. If your neuropathy has created numbness in your feet, and all of a sudden one day you're like, my foot's kind of sore, it's hurting, I don't know what's going on, it's a little red and it's painful, that is very concerning to me. People with neuropathy do not just randomly start to experience pain. Infection will often cause pain. So if you have pain and you typically have a numb foot, be on the lookout and make sure that you get some fevers and chills are some of the more concerning symptoms of infection that might be causing you to go septic or get very sick. And especially if your foot all of a sudden one day just looks very different to you. Maybe it's twice as big as the one next to it, or maybe it's got some different color going on. So anything that kind of changes suddenly, always be a little concerned about it. We always want to catch infection, again, because your foot is really at a high risk for developing a bone infection. So the longer you have a soft tissue infection, some little infection of the skin around that ulcer, the longer that sits there, the more likely that bacteria might multiply, have a party, get into the foot a little bit deeper, and then get into the bone. So we never want that to happen. We always want to catch infection early. And there's not like a great way of treating most infections at home. There's not great home remedies for infection, right? Antibiotics are truly probably our best way of treating those. Not something we want to just soak or do something like that. So how do amputations happen? So I kind of just touched on that a little bit, but essentially as that ulcer progresses, as it gets deeper or if it gets more infected, those are the sort of progressions of ulcers to possibly get to the bone. So if that bone is visible, if we can see it through the ulcer, that's always a concerning sign that there's a bone infection happening. And especially ulcers tend to go and get ugly quickly with even just a little bit of infection. So even if it was a superficial ulcer, say we've been working on it in clinic and it was doing pretty good and it was starting to heal up, but one day it gets infected, infection can set us way back and it can actually progress really rapidly where all of a sudden what was almost a healed ulcer can sometimes end up getting a bone infection even just from a bad infection. So infections will make the bone, a superficial infection can make a bone infection, but also just a deep ulcer that persists and doesn't heal can create that situation. So what happens when you come to see me? What do we do? Well, first of all, I would have you take both shoes and socks off. So just setting some expectations when people come see me. I have a funny amount of people who are embarrassed to show me their feet. And believe me, I have seen it all and I have seen the worst of it all. But we want to look at your feet. We want to look at your toes. We want to look at everything going on because especially if you don't feel things, someone else's pair of eyes is really crucial. Other things that we do. So I will always start out my exam testing your arteries. So we try to feel your pulses. You have 2 pulses on your feet. So first and foremost, I usually will try to feel your pulses. If I cannot feel those arteries, then sometimes we will use another little special device, which I'll talk about here, to listen to your arteries. Then we usually check on your nerve health. So if we are feeling different sensations, so sometimes I'll just see if you can feel first of all some light touch. If I'm using my glove, can you feel the glove touching your foot? And then we have again a couple of different tools I'll talk about. One is called a monofilament. This is hopefully something you're familiar with if you have diabetes, but it's a little plastic wire that we use to evaluate whether or not you can feel sort of that sharp versus dull differentiation. Joint range of motion, again, are you stiff anywhere? Do you have arthritis somewhere that's now preventing your toes so they're not moving as well as they once did? And if they're not moving as well as they once did, are we getting a pressure situation that's going to be problematic? Same with evaluation for deformities. Deformities, everybody has them. It kind of sounds like it's a big, scary thing, but a lot of times is there a high arch, a low arch? Are there hammer toes? Did you break your toe when you were 3 and it's sticking up in a weird way? Is it rubbing its neighbor? What's going on with it? The deformities is kind of a scary sounding term for just, is there going to be a problem with the way your foot interacts with itself and with the world? And assessment of skin, this is where we start to see, like, do you have thick toenails? Is your skin a healthy texture? Are you getting any signs of maybe not getting enough blood flow where your skin starts to get kind of thin? Do you have hair growing anywhere? That type of thing. Is there calluses that are now going to be problematic and become pre-ulcerative? And is there any moves? If you do have calluses, or say your toenails are in need of some work, those are things that you usually will take care of during your diabetic foot exam. So repairing the calluses, trimming toenails, and of course, if you have an ulcer, we will start initiating wound care, which is its whole specific thing based on what type of wounds you have. So here are those tools I just kind of mentioned. So on the left, again, that's that monofilament. That's a little plastic wire, basically touching it to your foot in several different places. I have patients close their eyes, tell me yes every single time they feel it. And if you don't feel it every single time, then that's a very concerning finding that maybe your nerves are not telling you the correct information. If you are feeling it, but you're not feeling all like, you're like, I have to think about it, like, yeah, I think you're there, I can feel it touching there, but you're not feeling like a sharp sort of sensation, You might just feel like maybe my hand is touching you rather than a sharp little kind of plastic wire. And that itself is also an abnormal finding. So that would tell me, I always tell people nerves carry every descriptive word out there. So they carry sharp versus dull, hot versus cold. And sometimes they will lose the ability to differentiate these small little things. So they might say this feels like pressure, but this doesn't hurt. And so that's still abnormal. That's still a loss of some of the sensation. And so that's just something to know, is that you might still feel things. You might say, hey, if I walked on a pebble, I would know that I was walking on that pebble. But you may not know if that pebble was really small and really sharp. If it actually, stabbed you and cut you, you might just feel pressure, right? The other thing on the right here, this is that Doppler. It's just a handheld Doppler. I'll use it to listen to see if you have pulses and make sure that your arteries are actually still down at your ankle. There's a few different things I'm listening for. Sometimes unhealthy arteries kind of just make a whooshing noise, that they're just kind of trickling down. They aren't really getting that good pulsatile compression that we hear in a young, healthy artery that has a lot of good elasticity still. And then if there was any abnormal findings with your arterial studies or feeling your pulses, then it would be probably the next step would be for me to refer you for some more vascular studies. And those usually start out with blood pressure cuff studies, where we are evaluating a couple different numbers of the blood flow from kind of your blood pressure cuff from your arm and your ankle. If those are abnormal, then I would probably send you to a vascular surgeon who could do, like a CT scan to evaluate, are you having any narrowing or blockages in your arteries anywhere? Is there anything that is significant that needs to be addressed? So vascular surgery sometimes is one of the next steps if I'm worried about blood flow. So how do we treat ulcers if you have one? First of all, we have to identify why it's happening. So one of the things I'm always paying attention to is what exactly is the cause of this ulcer? Is it deformity? Is it blood flow problems? Is it friction, pressure, infection? And then once you have an ulcer, and we decide, hey, it's from, say, a deformity or something like that, and the pressure in that area, what goes on next? Ulcers take a very long time to heal. They are something that your body develops an ulcer, and it tends to ignore it after it's started to happen, meaning that your body does not treat an ulcer the same way it treats a cut on your arm. It's not sending in these repair cells. It's not sending in these fighting cells to try to, get things moving. We see that there's a lot of damaged cells, and I won't go all the way into the cellular problems that happen with ulcers, but we see there's a lot of kind of damaged proteins in this area that just end up basically blocking some cellular signaling, and your body then treats these as like a chronic issue that they're not actively working on healing. So a lot of times with ulcers, one of the things we have to do is something called debridements. And the debridements are basically using a sharp little scalpel to scrape on your wound itself. Sounds really grotesque and horrible. Most people don't feel this. And so if they're not hurting or not feeling it, it's not as horrible as it sounds, but it's still, it's still getting your wound scraped on. And the reason why is we're trying to take off some of that bioburden and some of those cells that are inhibiting the wound to grow. So we're stimulating the wound to grow, trying to change something that's kind of chronic and ignored and convert it into an acute wound that your body says, hey, I should probably send some cells to do some things there. And advanced dressings, this is anything from an offloading dressing to some type of amniotic graft or something like umbilical tissue grafts, some crazy grafts with different cells. There's amazing technology out there about some of these things, and we use it when necessary. But really, the foundations of why the wound is happening is the best and most important thing that we can address. If we need to, we immobilize with using a cast or a boot. A lot of times when people are healing ulcers, motion works against us. So unfortunately with our feet, we use them, we have to walk, we have to put pressure through these areas. If we can lock up some of that motion, we can help these areas to heal, because they're not getting those repetitive stresses like you would in a normal shoe. So boots and casts are used fairly regularly. Management of swelling. So if you have a lot of swelling in your legs, that can work against us, because I always tell people you don't really want a hole in your water balloon, right? So if we have a little opening in the skin and you've got a lot of swelling, all of that fluid is going to try to go out those openings. And that can work against us because it's really hard to grow new cells over a kind of a little oozing situation. Most importantly, blood sugar control. If we can get that blood sugar under control, it's going to help immensely. But that's not always the only thing. Even if you have an ulcer and you have an A1C of 6.5, you may still have that ulcer if we don't have some of these other things addressed. Adequate protein intake is really important when you're healing an ulcer. So a lot of times protein is not prioritized in our diet enough. And for wounds to heal, we have to be basically producing new proteins. And so having enough in your diet is important. The recommendations are usually, it's a decent amount. It's about 1 gram per body weight, right? So it can be quite a bit of protein. Hard to even eat that much per day. So what can you do, right? So first and foremost, daily foot care is really important if you have diabetes. The biggest thing you can be doing is checking your feet and preventing these things from going unnoticed. So every single day, take a look at your foot. Take a look at the top, the bottom, in between the toes. And if you can't see it, try to use a mirror. And if you can't use a mirror to see it, try to get a buddy, right? So have someone take a look at your feet for you. It's always a good idea to just have good hygiene with your feet, wash and dry them well. This helps with some of that skin turnover, especially if you have that dry, flaky skin that we get with diabetes. And then moisturize to keep that skin healthy if you can. So there's not necessarily like a great moisturizer out there that I would tout versus others. As long as we're just looking at our feet, washing them, moisturizing them, that's one of the best ways of just not ignoring our feet. I think it's very easy to say, oh, stinky foot, don't want to deal, don't want to look at it, and we don't want to ignore them. So just kind of getting this habit of good hygiene, and that helps us to kind of pay attention. I would avoid moisturizing between your toes. Sometimes those little piggies, they trap that moisture. And then we can have a little bit of too much moisture in between the skin. So that's that little bullet point there. So make sure you're drying in between your toes pretty well. Change your socks pretty often, at least once a day. Try not to put dirty socks back on. I usually recommend white socks for people, especially if you have neuropathy, because if you do step on something, if you start to have any bleeding, oozing, anything like that, white sock is going to be pretty easy to say, hey, wait, what's happening here? I have something in my sock that made me bleed or whatever. If you have a black sock, you may not actually see that you have had something oozing all day. And then check your shoes. The amount of times I've had someone with diabetes and neuropathy come into their exam and have like a full extra wadded up sock still in their shoe, like an extra one, or like a little toy, like a grandkid's little plastic toy in their shoe, and they're just walking around all day long with something in their shoe. So please just feel your shoe before you put your foot in it. Make sure there's nothing in there that's going to sabotage your feet, okay? When it comes to nail care, if you don't have a lot of diabetes, you don't have a lot of neuropathy is what I mean to say. You probably might have a lot of diabetes no matter how you look at that. If you don't have a lot of neuropathy, or if you don't have any bad blood flow, which is something that you'll get assessed if you kind of come in for an exam, it's okay for you to trim your own toenails. I would recommend cutting them straight across so that we're not cutting into the corners of them. But I would definitely not recommend trimming on calluses or corns yourself. You can use a pumice stone to kind of soften them, but I wouldn't go crazy. The amount of people I also have who take razors to their feet or take Dremels to their feet, I just want you guys to be careful, okay? Your feet are important, and if something goes bad on us, it can go very bad. So it's just something to pay attention to. And if you have a hard time trimming your toenails, if you're worried you're gonna slip and cut yourself, if you're worried about your corns becoming ulcers, anything like that, see a foot specialist, and that will help manage these things. Most important thing you can do is maintain that blood glucose or blood sugar control. So American Diabetes Association generally recommends an A1C less than 7. We talked about an A1C over 8 is very problematic. And if you're young and healthy, try to even keep that number less than 6.5. Blood sugar is sometimes, I think with diabetes, it's such a chronic problem and it's such a burden. So you kind of get stuck sometimes on the numbers. You go to your appointments and people are always like, oh, what's your number? What's your number? What's your number? And I just want to emphasize it's not about always the numbers. It's about what it means, right? So blood sugar control, if you can keep your numbers lower, it helps to protect your nerves. It can improve your circulation. It can help your wounds heal. And it is so essential for your function to fight infections and just overall your entire system, your cardiovascular system, your kidneys, all of those things are so important. And so blood sugar control is absolutely essential.
I have a question from a viewer on Facebook. Karen is wondering, do vibration plates help with blood flow on the feelings we have in our feet?
Okay, so do you want me to repeat that, or do you think everybody heard that okay?
You can repeat it if you like. Just to be
So the question I think we just got was, do vibration plates help with the blood flow to improve feeling in your feet? Okay. So this question has a couple things to it. So vibration plates in and of themselves, I don't know that they essentially make a big difference in improving blood flow. I don't know the studies on them personally. I don't use them often, but there's a couple points to this that I want to address, and that is that sometimes the blood flow is what's affecting your feeling, but there's often two separate systems happening here, where your blood flow is one thing that's providing essentially all the nutrients to your feet. That's like your arteries, and then your nerves are what's going to be providing sensation. So the nerves are what may not really benefit that much from something like a vibration plate. So the sensation is unlikely to benefit from something like a vibration plate. And that is because the way that peripheral neuropathy happens in diabetes is that those excess glucose, excess lipids, so the sugars and the fats, as they overload our system starts to produce essentially these cells that cause death within the actual long nerves to our feet. So those axons of those nerves start to die off, and with that, the shaking and vibration and things like that, I don't exactly know that it's going to regrow those nerves. I don't think it's necessarily going to make a huge difference one way or the other. It's not something that I know a lot of studies on. But also, as far as blood flow goes, one of the best things you can do to improve blood flow that we'll talk about here are things like walking and moving. And vibration plates may add a little motion, but it's probably not enough to increase tissue demand, which is what helps your blood to flow a little bit better. So I hope that answers that question. But I don't know enough about vibration plates as far as the science that backs them up. And so I would say it's probably more gimmicky than it really is truly well supported by the evidence. And then as far as blood flows, this is a great kind of transition into this slide. How can we improve our blood flow? First and foremost, avoid any tobacco products. Tobacco is going to cause a constriction of your blood vessels that lasts for quite a while, and that does not help the tissue that needs that oxygen. Controlling your blood sugar and your cholesterol can also be important here. Those are just kind of with any of your cardiovascular health system, just trying to get all of that teed up and as healthy as it can be. And really, exercising is so important for helping your blood flow. As we walk, cycle, strength train, yoga, swimming, garden, any of these things that we do, the body is creating a situation that's asking for oxygen. And our vascular system is really incredible. It can grow little collateral arteries. We can grow all these little tiny vessels that provide oxygen if we need. And so asking it to start providing that oxygen can create a situation where it will help provide that oxygen. That being said, if you have neuropathy, I don't want you out here going on a 10-mile walk without looking at your feet, because a blister is going to set you back, right? So we have to be very careful about, if you are kind of feeling some numbness in your feet, to do your exercise, and when you are done, take a look at your feet. If you have any issue that came up, if you start getting a hot spot, a red spot, something like that, don't wear the same shoes and do the same exercise the next day. I want you to take a close look at that, and then we need to evaluate how can we get that exercise that we need without compromising our feet and creating a situation where all of a sudden you have an ulcer or a non-healing wound. Shoes do matter, so I recommend especially with diabetics with neuropathy, to wear shoes all the time. Because again, barefoot, I have seen everything in feet. I have seen someone with 11 needles in their foot. I have seen someone with kitty litter in their foot. I have seen everything. And so if you're wearing shoes, and your shoes don't have toys, and your shoes don't have extra socks, and your shoes don't have anything in them, the shoes itself will help protect you from a lot of what's in our environment. So definitely wearing a good pair of shoes can be helpful, even in the house. But check your shoes before putting them on and avoid walking barefoot, avoid wearing shoes that are too tight, high heels, narrow toes. And diabetic shoes could be something that is indicated. So you can sometimes get diabetic shoes if you have diabetes and you have a deformity or something that would predispose you to problems. And a diabetic shoe is truly, it's a shoe that is made to have a sort of, it's like an anti-blister type of insole in there that should help reduce the risk of blisters. It should also have a very soft top there so it doesn't cause any rubbing on your toes. This is a classic diabetic shoe. I'm not going to advertise that they're the cutest things that you've ever seen, but they are quite functional. So they can be helpful, right? I'd rather wear an ugly shoe than not have a leg.
Well, when you put it that way.
Yeah, I know. You got to sell it somehow, right?
Yeah.
All right, then when is it appropriate to get a foot exam? So if you have diabetes, at least once a year. Doesn't matter if you have anything else, but just diabetes, it's reasonable to come in and get a foot exam once a year. That's just something, kind of like a baseline annual check to see where are we at, how are our nerves doing, how's the blood flow doing, and if you have numbness, if you have poor circulation, if you have a wound or anything that looks concerning to us, then I start to see you more often. So some of my more high-risk patients, those with neuropathy and poor circulation, I'll see them every 2 or 3 months. If they have some type of wound, I end up seeing them every single week. So it's something that we don't want you to just think, oh, I have diabetes, but I'm okay. I don't want to bother people. You become good friends with your foot doctor, okay? And if you are worried at all, you just ask your primary care to take a look at your feet when you're at your visits for your primary care, and they can also make a referral anytime that it's needed. Okay. Key points here: look at your feet every single day. If I can emphasize anything, it's that. Small problems can also become very serious, and they can become life-threatening. Blood sugar control is the most important thing you can do, and you are also the most important advocate for your foot health. I want to emphasize to people all the time that you know your foot best. You know what your neuropathy feels like best. You know what it feels like when something is off. And if something feels off, get it looked at. And you may go into the ER and they might say, yeah, your labs are fine, everything looks fine. Because again, maybe you're not mounting the response that someone without diabetes might. But you are the most important advocate. So if you're worried about it, don't ignore it and be seen. And then regular podiatry care. We can help, with shaving off those calluses, keeping those toenails healthy, and also more importantly, we can help prevent amputations, foot complications, ulcers, and again, these things lead to very serious complications. So hopefully keep you healthy and on your feet as long as possible. Here are some references of mine, and that is all I have. Thank you. Any questions?
Have you ever had anyone come to you with foot problems and they didn't know that they had like diabetes but they have an ulcer and like you kind of started like that diagnosis progress? Have you ever had any kind of like that?
It isn't as common, but yes. So a lot of times it's not so much that I have someone walking into clinic and saying, oh, I have a wound that's not healing and then going that direction. It's more like their foot got really horribly infected without them really realizing it, and they went to the ER and their blood sugars were 1,000, and we go from there, right? Like they're often presenting with like horrible things, not just the small ones, because the small ones tend to go unnoticed. But I have had occasionally like some older patients that end up being diabetic or having neuropathy and didn't quite realize it, that maybe started out with a tiny wound or thick nails or something like that, and we just kind of start that process. So it can go the other direction. Usually goes diabetes to me, but sometimes the other way.
If someone's recently diagnosed with diabetes, depending on what their levels is, do you encourage them to come see you sooner rather than later, even if they leave with a clean,
Yes.
clean feet, perfect feet like now, but just kind of at least starting that progress to monitor it? Or
I tend to, because I think one of the most important things that a patient has is education, and I'm happy to always provide education. So if you don't know that 10% of people in the first year of their first diagnosis of an ulcer will die, you might not care that much, right? But if I can at least provide some education as to, let's try to keep you as healthy as possible so that we do not get these complications, then you know what to look for. You know that a callus can become an ulcer. You know these things. So even if they're perfectly healthy, I'm always happy for like an educational point, just to say, hey, this is what would scare me about your foot, and so this is what I want you to look at. And if there's nothing scary, amazing. Maybe I'll see you every year, and we'll go from there. But even if your diabetes is super well controlled, I think it's a worth a visit, at least get that education.
Okay.
What about you guys? Any questions? You guys are attentive students over here.
What led you to want to do podiatry?
Sure. Yeah. I think I just knew about podiatry for a long time. I come from a very active family, so both my parents and my brother are ultra marathoners.
Wow.
So they run like 100-mile races. So I've always known the importance of foot health. You have to keep those little piggies happy to be able to go that far. And so it's something that I guess I've just kind of always known about. And then when I was in high school as well, I also broke a bone in my foot. So I went to see a podiatrist. And he loved his job, and he was like, "You have to come shadow me. You want to go into medicine, like you got, all of this." And so I ended up learning a little bit more about podiatry from him specifically. And so then I just decided to, pursue that path because I think there's so much good that can happen by keeping people on their feet and healthy. If we can do some preventative care just in general and keep people active, your whole body is so much healthier because of that.
Yeah.
So it's a great thing.
Being new to the harbor and the service being so new, what's like a selling point? Like come see me, come see Dr. Opp. Like this is why you need to come here and see us, and here's your sign.
What is a selling point? Well, I am a very cheerful and educational provider, so I will just make your day. No, I don't know. I think in general, if you have a foot problem, a podiatrist in general can usually help address that problem at your visit. So one of the nice things about podiatry is I have a lot of patients who leave feeling better than when they came. So that's one of the nice things is that a lot of times there's something simple we can do, either changing something with your pressures of your foot, injections, toenails, you name it. There's like some type of hands-on thing we do that usually helps you to at least have a little bit less pain leaving than when you came. Or maybe a little bit less problems, right? Just kind of depends on what you came with. That's one of the nice things about seeing a foot doctor is it tends to be pretty focal, addressing your problem, getting it taken care of visit.
How many out of all the feet that you see, all the patients, about looking at your patient panel, how many of them, like what percentage is more like diabetic foot compared to just other foot issues, ingrown toes or bunion or whatever?
It's very geographical, right? So it kind of depends on where you're at. When I was in Colorado, I was working in a very healthy community, a very healthy, active place, and it was definitely probably biased towards more like biomechanical things that I see from like a lot of runners. We had a lot of people who were, having stress fractures and plantar fasciitis and that type of thing. And in this community so far, I would say probably about 50% of diabetic versus otherwise. Yeah, there's a lot of my patients that are diabetics. It could be even higher than that. I haven't done the numbers, but it's probably at least half of my patients every day.
Okay. Wow. I can only imagine, like, I'm just blown away how much. I mean, I've been in the medical field, but not focusing on podiatry. And like anyone, just know like the basics of what can happen if it's untreated, so on and so forth. But I'm just blown away at so much that goes into it, down to your diet. Like when you think of your feet, you don't think of how's my blood sugars, how's my diet, am I getting enough circulation? So to me, that's like just another eye opener. Like, wow, I should probably get myself in check and make sure that I'm doing good. So I can only imagine how much you're just going to blossom, because this is going to be such a huge service to the community and people that don't know that they should really get in and get their feet checked out, and diabetes and all that kind of stuff. So I am very excited that you're here.
I'm very excited.
And I'm excited to see what how the community is gonna respond to you and see you do great things in the community.
Thank you. Yeah, definitely. I think there's so far from everything I can tell a huge need for good foot care. And so I'm happy that we're here, and Summit is such a good community to be able to provide, all the care, right? So it's so nice to be able to say, hey, I'm going to reach out to your primary care and maybe ask if they can do this for you when we're treating this, right? So it's really nice to have that connectedness where the specialists and the providers can really communicate, because I've been in situations or seen situations where you sometimes have like a one-off office, and it's a little harder to reach out to the primary carers and to the people who really have the quarterbacks of the care. So it's been great to really be plugged in and have all the resources in one spot, and just I think there's a huge need, and education is one of the foundations, right? So the more people know, the more you can get checked out, and so happy to always provide education.
And last question, I promise. What is one shoe that you would tell everyone absolutely you do not recommend, like Crocs or Birks or stilettos or
one shoe I don't recommend.
Like they just walk in and they're always wearing that. You're just like, you need to stop wearing those.
Yes. Honestly, okay, so any like stiletto is going to be problematic, but most people don't walk in wearing stilettos. But stilettos, I worry about ankle fractures. I worry about the pressures that are going through your feet. There's a whole bunch of things with stilettos. Honestly, one of the shoes that is somewhat problematic for anyone who has like foot pain or problems are like the Skechers shoes that are really flimsy and they're really flexible. So they're very popular because they're very affordable and they're everywhere, but they can be like a shoe that you can just bend in half and twist in half. That's offered no support for most people, and so if you have foot pain and you're living in a shoe that's super flexible, the shoe is not working for you. Your foot is having to take all of the ground reactive forces of walking, and it's doing all the hard work. The shoe's not doing much. So a shoe that is stiff and you can't really bend it or twist it is probably always what I'm going to recommend. And so there's a range. There's some really good Skechers and there's some very flimsy Skechers. So within every brand, you're going to have more supportive and less supportive, but that's always my rule of thumb with shoes. That's a good question. Yeah, I get that question all the time. But yeah, no stilettos. Please don't wear your stilettos to see me. I will just smile, but I'll be inwardly very concerned about it. Or ankles.
Or referral to psychiatry.
No. I have not seen many stilettos here, that's for sure.
Yeah.
I know about shoes because I think I have parents not very good.
Okay.
It's supposed to be good,
Yeah.
but you're right. They do get a lot.
Especially, I always get this sort of argument from people like, maybe we need more like flimsy or barefoot shoes, and that's better for our feet. Like I hear this out there, and that may be true if we lived in surfaces that our feet could be flexible and we could have these strong muscles. But we live in concrete jungles. Like we're on our feet all day long in these concrete places. Our linoleum floors, our hardwood floors. Like we don't live in a place that has like soft ground all the time. If you're outside and barefoot and it feels good, that's great. But if you're inside and you don't have that support, your feet are aching usually. Yeah. So that's kind of my thought with it.
I like this. Will be the last question. It's from a viewer.
Okay, great.
What is the best moisturizer to use?
That's a good question. So as far as just general moisturizer, I like a CeraVe. So you can buy the over the counter anywhere, CeraVe. That tends to be a really good one. If you wanted to gravitate more towards a cream versus a lotion, it's going to be a little bit more moisturizing. So lotions are water-based and creams are oil-based usually. And so creams are going to be a little bit thicker. They're going to be a little bit better for actual moisturizing. And it's a good idea to apply them after you shower because your skin might be a little damp from the shower and you basically are trapping in that moisture once you put that lotion or that cream on. So CeraVe is probably one I know that's a very good one. A lot of people don't have any allergic reactions to it or anything like that. For calluses specifically, I like to recommend Urea cream. So that's Urea. And really there's different products over the counter that have different strengths. If you have bad calluses, I recommend the highest strength I can find, which is 40%. And usually that's like Amazon. So Urea cream from Amazon, 40%. Other places have like 20%. I know like different like drugstores have like a 20%, and those would work as well. Usually they're mixed with a couple other things. But I always tell people the properties in urea help to, they actually have like it's an enzyme that helps kind of break down some of the proteins that form calluses. So that can be helpful. Hopefully that answers that question.
Perfect.
Okay, are we good?
We're good.
Thank you guys. Appreciate you guys coming.
Thank